All right. Well, welcome everyone to the town hall for NASW-PA. I am Johanna Byrd. I'm the executive director with the National Association of Social Workers Pennsylvania chapter. And well, first off, happy Social Work Month. And secondly, thank you for joining us for this town hall. I'm going to introduce our panelists of folks who are here with us today briefly, with one addition that Christy Jo King, our president, is planning to join us when she's available. She has a client in crisis, something that I'm sure many of you can identify with, as far as like why that would throw you off your schedule. And she's going to, as I said, she's going to join us as soon as she's able. But like I was telling folks earlier, and as I said, like I'm sure many of you understand, if that ends up being never, we'll all, we'll all understand that too. All right. So first off, I'd like to introduce Angie Armbrust and Natalie Cook as our lobbying team. Can you say hi for a sec?
Hi, thank you everyone. I'm Angie Armbrust with McNeese Winter Group, and we are the contract lobbyists for NASW in Harrisburg for state government work.
Hi, I'm Natalie Cook. I work with Angie. Thanks for having us.
And then next, Troy Brindle is the chair, co-chair of our clinical care committee, past NASW-PA president, past national board member, and a few other things. Troy, thanks for joining us.
Hey, you're very welcome, Joanna, and it's very nice to be here. I'm going to kind of go on and off camera because I kind of have Zoom fatigue right now, so I'll be, sort of on and off, but I'll definitely be present. Okay.
Completely understood. I think I have maybe a little bit of Zoom fatigue too. So, so yeah, we'll get started. So again, this is a town hall meeting, which one of the things we like about our town halls is, hearing from you as much as, talking ourselves. We don't have a really tight agenda planned for today. We don't have, we don't have a script or PowerPoints or anything like that. It's really just an opportunity for us to have a conversation, and to kind of talk about where things are, to hear from you. In this one in particular, it's going to be really important for us to hear from you, and I'll get into that a little bit more later. But I wanted to start off with just sort of talking about like where telehealth is right now in Pennsylvania. In the past, prior to COVID, we've been in this situation of that telehealth has never been against the law in Pennsylvania. It's always been, it also hasn't been specifically allowed under the law either. So it's always been in sort of this zone of like, not exactly being prohibited, but not exactly being permitted either. And where that ends up, or where that tended to fall prior to COVID in particular, was that there was a lot of uncertainty about whether you could do telehealth or not. A lot of it ended up depending on the insurance companies that you were working with and whether that particular insurance company would reimburse for telehealth services or not. We definitely heard that some telehealth services were we're being reimbursed at a lower, so sometimes much lower rate than than in-person services because of, I guess because of just the technology difference or the presumption by the insurance company that there was a lower overhead cost in doing telehealth. And so that's where we were, and not a lot of prior to COVID, again, I think we had always been working on having a comprehensive telehealth bill in Pennsylvania as part of NASW-PA's legislative agenda. And I'll turn it over to them to kind of to Angie and Natalie a little bit later on to kind of talk about the legislative process in a few minutes. But that bill never became law for a variety of reasons. And then of course COVID hits, and and the whole world changes overnight, and we're all like, and the only way to access services was via telehealth. And then things started to change. Now we worked directly, NASW-PA did, with the governor's office at the time to get certain waivers in place that would allow for those changes to happen. I think most people are relatively familiar with what's happened since then. The waivers have, well, at first the emergency declaration from the governor kept getting extended. Then after the governor's authority to extend the emergency waivers was removed, the legislature has since extended it a couple of times. That is currently scheduled to end March 31st of this year. At least my understanding is it's looking like that's going to be extended through June, but of course, no commitments. And then we have, but that's where we've been so far. And so we get into the need for like why a comprehensive telehealth bill is necessary, because this isn't something that are, out of a lot of the other waivers that have now since become permanent, it's been because like our licensing board did it, or the governor was just able to do some kind of executive order. This isn't the kind of thing that can change that way. So really the only thing that's going to make a substantive difference is for the General Assembly to pass a bill. And with that, I'll pass it over to Angie to give you a little bit more synopsis of like where that's sitting.
Sure, thank you. So yes, everything that Johanna has said is true, and it is certainly frustrating for practitioners in the field like yourselves to constantly be dealing with this throughout the past year and a half of the emergency declarations, being extended, that uncertainty. Insurers sometimes reaching out to you to contact you to say, as of this date, we will no longer reimburse. And then, waivers and suspensions getting extended. So yes, the current policy suspension is through Department of State that is allowing comprehensive telehealth in Pennsylvania. Background on this session, the telemedicine bill is Senate Bill 705. It passed the Senate fairly quickly last fall. I think it was voted out with only, I want to say, 4 negative votes, sent over to the House in late October. And this time it was referred to the House Insurance Committee. So that's where it has been sitting since late last fall. When we do outreach on the topic, we sometimes hear legislators say, well, do we really need to do this law because telemedicine's a thing now, like we do it, it's already being done. And then we explain that it's being done because of the temporary policy waivers and extensions. And yes, even if all that goes away, maybe telemedicine would continue in some form or another, but there would be a lot of confusion in the field and a lot of uncertainty around reimbursements. So that's the need for the comprehensive framework here in PA. A little historical background. This is not the first session we've taken up telemedicine. It has come through a few different iterations. Usually it's been introduced in the House and Senate, but the bill that has always gained traction is Senator Vogel's bill throughout the past couple sessions. And again, it seems to be able to pass cleanly through the Senate, gets to the House. It's been in the House professional licensure committee at one point. Another time it was referred to House Health Committee. As I mentioned, now it's in House Insurance Committee this session. But either in committee or on the House floor, there's that faction in the House that attaches pro-life language that the governor absolutely will not sign into law, limiting a woman's ability to choose. So that's the poison pill that keeps getting added in each session, which I think last session was the time it actually made it the whole way to his desk and he was forced to veto the bill. So that's the historical background. Natalie, is there anything I'm missing?
Thank you. Nailed it.
All right, sorry, I had to unmute myself for a second there. As is our typical Zoom experience, how many times do we all like just start talking and then suddenly realize that no, that you're talking to yourself? So are there any questions from like our audience about like that part of things, like where either through the chat or anything else about just like where that sits right now, like what's allowed, what's not allowed, what we think is coming? Sorry, just kind of following what's in the, yeah. Okay, most of the things in the chat are just folks signing in or getting me those like notes about people who haven't been able to log in or that sort of thing. There are, so sounds like folks I think are pretty well settled on that. What I can tell you is that this is a big advocacy issue for NASW-PA. It is something that we're meeting with our legislators on. It's something that will be the primary topic of LEAD, our upcoming Legislative Education and Advocacy Day. We feel very passionate about the fact that that telehealth is essential for not only as our members, social workers and how we practice and enabling us to practice the best that we can, but from the client perspective as far as access to services and that sort of thing. But like what Angie said earlier about our legislators not necessarily seeing the need, like why do you need this bill to pass, is important. Carly, I see you have your hand up.
Yes, hi. I did want to ask kind of just a clarification question, Angie. When you said that it keeps getting kind of stuck in like a House committee because it's being attached to pro-life legislation, could you speak more about that and what it would take to kind of have this be a standalone issue or not be attached to something else that traditionally gets a lot of split response in the House?
Sure. Yeah, I can expound a little bit about what the language that was added in last year. And Natalie, I might rely on you to fill in details because it's been a while. The amendment that got attached would would make it so telemedicine could not be used for medications on the REMS list.
Correct, the REMS list.
Which includes a variety of drugs that not only abortion medication, but acne medication and lots of other things that absolutely could be, with counseling with a patient, could be prescribed via telemedicine. Those are on a list because they require additional education to your patients and care to take care with using those, but kind of couching it in those terms of, well, if this drug is on this list as of a specific date too, it was very, very specific, then telemedicine could never be applied. So that was the language that we saw last session. And yes, it does seem like you should be able to advocate for keeping these two issues separate. And believe me, lots of people are trying to do that. but there is a faction that will not pass up an opportunity to bring their issue to the forefront. So,
For explaining that. Thank you.
sure.
Yep, that's definitely something that is part of our messaging for LEAD and for our advocacy in general. That we, again, that isn't the first version. That was the most recent version of the amendment. I think the one, if I'm recalling correctly, the one from like 2 years ago, or not
Prior session.
probably like the prior session, prior to like the last session and then the session before that.
Right.
Last session was the one that had the REMS lists language. The session before that, as I recall, it had an amendment that was sort of like, well, you can't address any sort of like abortion related services over telehealth, and just like spelled that out specifically, which could have serious implications. We were even more vehemently against that in particular language, because obviously like counseling and mental health services could, when we're discussing abortion, when we're discussing past abortions, potential future abortions, it could end up, in that realm of like, of being abortion related services be happening over telehealth. The REMS list, since social workers don't prescribe medicine, it obviously has a lot less direct impact on like us and what we do. Because and nowhere in mental health, I don't even think there's many, if any, like psychotropic medications on the REMS list. So it wouldn't have any kind of like direct impact on social work services, but it would on like the healthcare services that are a part of, that are a part of it. But yes, we are like, I don't know how effective it will be, but I mean, obviously where we're kind of heading with this is just that this is such an important piece of legislation, and that it needs to, and that it's something that needs to become law, that we've seen how it is from the waivers, and how it's been actively happening in Pennsylvania these past couple of years. And that if we want those services to continue uninterrupted, we need to get something passed, and it needs to be something clean, so that the governor can sign it and that we can go ahead and get it taken care of as, just law in Pennsylvania. I don't think that will necessarily be effective in convincing the people who want to propose this amendment to not propose it. But potentially they could be redirected if we could potentially reach leadership, or if we could, convince enough people to vote that amendment down. Again, all things that are possible, but have not yet been effective in the past. And that's where advocacy and reaching out to our elected officials and kind of proving our case really comes into play.
Yeah, and I think too, just to chime in, to add on to that, and reiterating why we still need a law, even though it's almost common practice now that people understand what telemedicine is and people like it. And, we hear legislators say, well, it's not going to go away because people like it. There'll be a demand for it. Yes, but we still really do need that clarity of how it can be carried out here.
We had a question in the chat about if we could provide a high-level summary of what's covered or not covered in the bill. Angie, are you comfortable talking about that?
Sure. If you give me just a second, I will pull it up. So I'm just 1 second.
Okay, well, while you're doing that, we also had some folks ask about who was on the insurance committee, and I looked that one up, or at least had that on my page. The chair of the insurance committee is Tina Pickett, and then the Democratic chair is Anthony DeLuca. Tina Pickett, I believe, is somebody that we're maybe supposed to meet with at LEAD, or at least are working to schedule a meeting with her. For some reason, when I click on the rest of the list, it says like, to see the rest of them, click here, but then it just gives me a list of all of the meetings. But there's the chairs.
We can send out a list, or I can read, if you want me to, I can read them off. I have them pulled up on a different site. I can go through them really quickly. Tina Pickett on the Republican side, Representative Tina Pickett, Representative Stephen Menser, Representative Bud Cook, Representative Aaron Bernstein, Jonathan Fritz, Rich Irvin, Eric Nelson, Tim O'Neill, Michael Puskaric, Chris Quinn, Greg Rothman, Lou Schmidt, Jim Struzzi, Wendy Thomas, David Zimmerman. On the Democratic side, Chairman Anthony DeLuca, Morgan Cephas, Austin Davis, Jason Dawkins, Michael Driscoll, Patty Kim, Bridget Kozarowski, Jeannie McNeil, Robert Mursky, and Perry Warren. So if any of these names sound familiar to you, you recognize.
Where are we with getting letters of support from our counties and the Department of Insurance and the people that, the commercial insurance companies? We're what, 2 weeks away from this event? Where are we in our to get this done?
Michelle, we can't quite understand you. I don't know if you have access to like maybe get a little closer to the phone or or the microphone or anything like that, but you were very muffled. There's a question in the chat about like if there were efforts to collaborate with allied professions such as LPCs and their respective organizations to add to a list of supporters. I can address that to an extent and say that there are a whole like coalitions of groups that are working on this jointly. At least 2 groups that I'm familiar with. Including the Coalition for the Common Health and the I'm blanking on the name of it, Angie, the other group that we meet with.
The Alliance of Healthcare Providers and also the Pennsylvania Provider Advocacy Coalition, which is made up of different providers and facilities, all advocating strongly for a clean.
Nearly everybody we work with in this space that has a healthcare client or healthcare related entity is weighing in on this bill. Everybody is putting effort in the same direction.
And
right, because definitely it impacts it's not just a mental health bill, it's a medical health bill as well. And the Pennsylvania Medical Association is on board. In addition to, like we said, every medical coalition, every mental health coalition, every like specific healthcare related or affiliated group is working on this in some way or another. All right, I'm checking through. We have so certainly this bill does have broad support, and it even has broad support among the legislators. I mean, we have to remember that despite the fact that the main problem with this bill is not getting the support from the legislators to vote it up or down. We've already passed it last session. We just passed it with language that ended up resulting in a veto, because of, like we said, about that that choice related language. But yeah, even like both sides have definitely strongly supported that. It has broad numbers of, like, how many co-sponsors does this bill have?
A lot.
A lot.
I don't know off the top of my head. But to go back to the question that someone had asked me about what does the bill allow you to do? Actually, this version would empower the state licensing boards to regulate telemedicine. And it would require insurance coverage of telemedicine and for payment to healthcare providers of telemedicine services. So it's a more broad overarching bill. I think we have seen in previous sessions where they tried to specifically name who could do what, and that very quickly became mired in a lot of, lots of kind of turf war type of discussions. So this is kind of giving the authority to the licensing boards, who presumably should know their practice the best, to regulate how what each profession can do.
And I think too, this bill is a little different from some of the previous iterations we've seen, in that the pandemic helped them clarify some of the language around what types of technology you're using in telehealth. The language was a bit muddy in previous iterations, and this one's much clearer. And I think the pandemic actually helped in that sense, because it helped them see what people really are using and what should be included in the bill, what kind of language should be used in that way.
Yes, absolutely. A silver lining of this ordeal has been a simplified, streamlined text of this legislation to say, it's being done. It's being done through a waiver of Department of State, through the licensing boards. They have the authority to give that guidance. Let's hand it over to them. And then realizing too, not to get overly specific and prescribing specific technologies or platforms, just a minimum standard for privacy, and then kind of moving on there, acknowledging that technologies change. One quick note too about technology. One thing we had kind of heard the past two sessions about, I won't say an excuse, but a reason to not act so quickly on telemedicine was that internet access, broadband, is severely lacking in a lot of parts of the state. So that has been somewhat addressed now this year through the creation of the Broadband Authority, with some use of federal funding to really beef up that infrastructure here. Which for some legislators had always been used as kind of a stepping stone. Before we can address telemedicine, we really need to get to this access issue. So that box is checked off now too.
Okay, we do have a few more questions in the chat. That was, I think, which may have been what, when we couldn't hear Michelle earlier, she was asking about letters of support from like insurance companies or Department of Insurance or the Department of Human Services. I know sometimes our state agencies are reticent or sometimes not even legally allowed to take a particular position on a particular bill. But is there anything that you've heard that way?
No, we've really had most of our conversations through the governor's office directly on this, some through Department of Health as well. And the entire administration is really anxious to see this issue put to bed. I think the better, and it would be a relief, I think, for the governor to get this done. So they are very pleased to hear of groups like us advocating for telemedicine and kind of still out there carrying that drumbeat of why we still need to. It's one of those things that's kind of fallen off the radar because redistricting and elections and all, lots of other things grabbing attention. So kind of bringing this back to the forefront, back to the center of conversation as we're coming up again on a waiver extension. And then even if it gets extended again, you as providers shouldn't have to work your practice life around these deadlines like this. So sharing your stories, I think, is going to be very important.
Yep, and I know just for an example, the last time the waiver hit, the waivers were extended was literally the day before they expired, which I'm sure because I remember, yeah, the day of the expiration, because I remember we were sending out a bunch of notices and talking to folks and trying to make that like ease people through the transition as much as possible of preparing for what services were going to be like the day after the waivers expired, and that folks were already sometimes getting letters from insurance companies saying, after these waivers expired, we're not going to reimburse for telehealth services anymore. And so, yeah, I know that those changes happening at the last minute is just as disrupting as if they, as if they actually happened. So, yeah, and I guess there's also a question is if there's an effort to get clients to share their stories. We're focusing more on the provider end of things, including, and we're actually going to have a time later on in the session to really, to even have an opportunity for some of us to share our stories now in a way, when Angie and Natalie can hear that and bring some of those stories back to the meetings that they have on our behalf. So kind of be thinking of those in the back of your mind, and we'll bring those up in a second. But in the meantime, while we seem to not have a ton of extra questions in the chat, I want to pass it back over to Troy. Troy was going to talk about a telehealth report that was conducted in PA a little over, I think you said a year ago. So Troy.
Yeah, so there was a lot of advocacy and just highlighting the concern that we all need to be vigilant and advocate for passage of legislation to secure where we need to go as a provider system. Telehealth absolutely is a valuable tool that we've used throughout the pandemic, and we've seen the entire pivot very quickly to the acceptance of telehealth, even by payers as well as by providers, and most importantly by the consumers, by those who we serve and treat. So Pennsylvania, I'm currently the chair for the steering committee for the Coalition for the Common Health of Pennsylvania, and work in partnership with many other provider organizations, including OMSOS, the Department of Health, and the survey that was conducted over a year ago, which was a proactive survey with the expectation that we would find ourselves as a provider system in a threat of telehealth being taken away, was conducted across over 3,000 Pennsylvanians, and it was conducted to families, to medical providers, to behavioral health providers, to organizations, agencies, and to individuals, to direct consumers. So it was a very comprehensive survey, one of the largest surveys ever conducted in Pennsylvania, and had successful response. We had an overwhelming response rate to the survey that indicated some really unique findings, and findings that now to this group would probably not be too astonishing because we've lived with telehealth for a couple of years. But at the time, it really highlighted access was number one, the ease of access and the capacity to get people the help that they need wherever they're located. The second finding that resulted from the course of the survey was the engagement, that it had a very high level of engagement, that people were sticking with treatment, navigating treatment, and benefiting from treatment, whether it was by telephonic or by video conferencing. We saw the ease for people to get help from the comfort of their own home. One of the cool reports that came out was how parents with little kids would struggle with being able to get appointments outside of the home. But what they were finding is higher rates of compliance and less cancellations. We know less cancellation of no-shows was a big factor of this. No-shows dropped considerably for providers. And, parents were able to do this from the comfort of their own home. So they didn't have to worry about securing childcare. They didn't have to worry about navigating the needs of their children, because the children could either be cared for by someone else in the house, or they were present. Another key finding in this was, the rate that people would complete treatment was also a higher rate of completion of treatment. It helped prevent isolation and loneliness. There was efficacies around depression. We saw like a higher level of engagement around those who were struggling with depression and anxiety. And I think one of the things that people were most in tune with was that they didn't feel slighted by not having someone in person. They actually felt a little bit more comfort by being able to do telehealth. So those are some of the findings that we've used to leverage across the system. The threats that we identified was the payer's intention at some point to cut telehealth services, leveraging arguments around the overhead and the costs not being the same. And we're seeing that play out now at a large level on the commercial side, where some of the payers are looking at pulling back some of the payments for telehealth services on the behavioral health side. And what I learned yesterday, CMS, is looking at cutting, reimbursement for telehealth on the behavioral health side. So those are some things that we have to sort of guard against and navigate and, kind of work cooperatively around our advocacy efforts. So the report was pretty comprehensive. It was very, I'm just giving a high level overview of it, but we've used that information in cooperation with other agencies and organizations to really leverage the value of this service and the importance of this service. And I am one that does believe telehealth is here to stay. We're going to be moving to a hybrid model and hybrid approach. And eventually we're going to have to get, some of these things that have been put forth legislatively passed, so that we can continue to provide the services. We also need to deal with some of the other complexities around Hipaa, that was loosened up over the pandemic. We're going to have to continue to navigate that conversation and hopefully see regulations around Hipaa loosen a little bit. And we also have to deal with licensure portability is another big factor with telehealth services. They're all entwined, as Angie and Natalie and Johanna know. But that's just some of the conversations. So yes, we are heavily pushing the advocacy for this bill, and we need it. And I don't think it's if we get it, it's more just when do we get it. And I think for a lot of people, we feel we should have had it by now because we need to move on and deal with other legislative things that are equally important. So.
Yeah, couldn't agree with that one more. I think we're, kind of because of some of the uniquenesses, the unique qualities of Pennsylvania, we're one of the few states that, don't have a telehealth bill in place. Going into the pandemic in the first place. I can, because of what Troy was just saying about portability. I want to tell you a little bit about something that is happening with portability, just as a heads up, and then I'm gonna kick it back to maybe asking a couple of more clinical questions for our for our more clinical panelists. All right, so portability wise, one of the questions that I get all the time, one about just what are we doing about portability, or why can't social workers have something like the nurses do with having a compact in place? I've even had a question like directly to me, like, why can't we just join a compact and get a bill like that passed today? And I'm like, well, first off, we can't join a compact until there's a compact for us to join, which is the really important first step. But I can tell you that NASW, along with ASWB, and got some kind of contract working with the Department of Defense, because I think most of us know that a lot of portability issues sometimes relate to like, or one of the populations most impacted by portability is military, or especially military spouses, as military families transfer from base to base and, have to get relicensed all over again in whatever their, in whatever field of practice that may be. And so that has been, so anyway, they're working with the Department of Defense to establish a compact, and that would, I believe that the committee that has been talking about that has met. Where they are right now in the stages is that they're getting some sort of draft together of like what the language of that would look like. There's a lot of like questions about what would be included. For example, if, one state requires 3,000 hours of supervised services and another state requires 4,500 hours of supervision, where do we set the minimum for that to join the compact? If folks were grandfathered in to their licensure, do they also grandfather into portability? Lots of questions that would need to be addressed. I don't have the answers to any of those questions now because I'm not on the committee that's like looking at the draft. I can only tell you that that's where that is, and they hope within the next couple of years or so to be at the point where we can start like actively getting states to join. In which case, that will probably become because we're hoping that it might even be that Pennsylvania could be one of the first states to join, as opposed to one of the last, like we are on a lot of other things. When we passed our practice protection bill, we were the 49th state to have practice protection. So that was a big deal. But yeah, we want to jump on that and hopefully get that started. But to just know that portability piece exists as well. The nurses do have a compact. I believe the psychologists have a compact. There's, that's kind of a model that has worked well for portability thus far, that I think we're seeing in other professions around the country. All right, so Troy, so I know with Medicare, that one of the things that was included in COVID waivers, et cetera, was telephone only services, because of like poverty, because of people who didn't have access to those Hipaa compliant portals. And so what, from a clinical perspective, what are your thoughts on like those telephone only services, and like balancing privacy and HIPAA with like access to care?
Yeah, no, it's a great question. So I conducted some telephone only sessions. They're definitely harder. You're missing out on the physical presence of somebody or being able to see them. But I can tell you for the older adult population and some of the folks that I work with, they were very engaged on the telephone only process, and they were just as open and communicative. As a clinician, I really like reading the nonverbal cues of somebody. You just don't get that. So what I did do is I worked with some of the older adults to eventually be able to like use an iPad or to navigate something or to have son or daughter come over and help them navigate a phone. I think there's some value in, trying to mix that up the best you can, but in a situation where there's disparities, and we saw a lot of tech disparities, we saw a lot of internet, inequities, during, even in our own school district, there was inequities, right? And I live in a fairly well-to-do area, and it has nothing to do with that. It's just, access is access. And one of the things that was really cool about the telephone only process is that, in a world that literally shut down and pivoted overnight, and people were isolated and alone, and some of these folks didn't have family or kids or friends to check in on them, it really became a lifeline. So I'm really glad to see that the pathway forward to telephone only is there in the CMS ruling for telehealth. But I think there's stipulations to it. I believe you have to have an in-person visit every 6 months. It can't just be telephone only forever. But I think for some, it's meaningful and helpful. It'd be interesting to hear other people's thoughts on it as well.
Wanted to check if there is anyone who wanted to address telephone only services.
Yeah.
Okay, great.
I would. I'd show myself, but I don't think people would like to see a green mask, literally green mask. But anyway, so what I can tell you is that across the board with the folks that I've seen through with telephone, across the board, over 90%, and I've been keeping track, over 90% won't do it if they have to utilize the computer. So and of course, I, like Troy mentioned, and many of you probably will say, well, gosh, you can't see them, you can't get that feedback. And I'll tell you what, I brushed up on my skills to deal with folks over the phone, and I can hear when they breathe funny, to be honest. So I think that, or they sigh, just simple things like that, or they say nothing, of course. But, I really think that allowing these folks to choose is going to be extremely important for us to know, and then for us to respond, with that quantum leap.
Yeah, I also find telephone work more challenging, but I also find that many of the clients particularly grateful. What I've been trying to do is send more material to them, so that they're getting something from me in hand. And then the other thing I've asked them to do is, if I was sitting with you and I could see your face, what would I be seeing? Or if I were sitting with you, what would your hands be doing? What are they doing now? And letting them be descriptive. But I've just been amazed at the depth of gratitude for connection. And some of the people that I have worked with are just not comfortable with technology. I mean, they're worse than I am, which says a lot. I've learned a lot during this period of time. I've gotten much better. But I'm really concerned about if that gets cut off, because these are not people who have access to come into the office. And then what? I think, that will really, really be concerning. So, yeah.
That kind of leads me into, go ahead, Troy. I'll go after you.
No, I just wanted to respond. I think it was Ann put in there. Can you tell us more about the CSM ruling? Yeah, so CMS ruled November 2nd of 2021, which is effective now, that reimbursement for audio-only services for mental health will continue after the public emergency ends. And that's from the Centers of Medicare, CMS directly. They also talked about additional requirements for audio only services. And I'm just reading this real quick, is that the American Psychological Association, advocated against imposing additional requirements such as periodic in-person visits or additional documentation other than a modifier. Under the rule, once the emergency ends, audio-only telehealth services for mental health and substance use disorders will require an in-person visit within 6 months of the original initial audio-only visit and within 12 months of any subsequent telehealth visit. So that is the ruling. So as I say, CMS has spoken for now.
That, which of course impacts Medicare. It impacts Medicare.
Medicare and Medicaid
doesn't necessarily Medicare and Medicaid, which doesn't necessarily translate to anything beyond that.
That is correct. And commercial payers typically will follow suit. They will take their lead in Medicare. So when Medicare makes moves to do cuts or to do additions, it's interesting because, and I'd like to get people's reaction to this, but on the one hand, they expand telehealth. Medicare expands telehealth, but on the next hand, the expansion of that also comes with budget neutral, which means there has to be some cuts in there along the way. And I'm seeing a thing from Robin about Western PA, large commercial insurance, UPMC, which we all know, amended their telehealth policy to disallow reimbursement. So for audio only. And all I can say is I just think that is short-sighted at times.
Mm-hmm. Understood. But yeah, I appreciate our folks, Jennifer and Barbara, for sharing your experiences with that telephone only services. Wondering if it would maybe be a good time. It's nearly almost 7 o'clock. We have like a little over half an hour left. I think it would be really advantageous. Again, not only from, one thing we're thinking about doing in the near future, possibly even like this week, is like sending out some sort of survey to our members to share those stories so that we have them accessible, about like what the benefit is, what the need is for telehealth. But yeah, even just hearing those verbally now, helps inform our lobbying team, helps inform me as more of an administrator who is not like out there in the field about like what you're seeing with your clients, and get us kicked off with that. I've heard a couple of really great stories from Marietta, who is on the call and agreed to share her stories. So Marietta, can I ask you to chime in?
Sure. One of the things I just heard today on a video session with one of my clients who's going to be having major back surgery shortly, is that she was very appreciative of telehealth and has been using telehealth, the video portion of it, because she will not be able to drive for a good portion of time. And with the nature of the surgery she is getting, she would have to just stop her therapy for a period of time. So that was really powerful. And that literally just happened this afternoon, that she shared that with me. I was jotting down some other things too. And one of the things that I thought would be an issue when we first started in converting over to telehealth has turned out to be the opposite. So I want to share that as well in terms of confidentiality. I have had several clients say this to me, that they felt better able to share private information talking from their home than they would talking in an office, than they would going into an office that has a nice big sign on it that says mental health practice. They did not want to sit in a waiting room, a crowded waiting room, perhaps running into neighbors or friends or colleagues. They felt much more secure in talking from their own home because they can control their environment. So they can go to a private space. I've had people talk to me from garages, from parked cars, from parking lots, you name it, from a grocery store parking lot, going to pick up their kids from school, which is sometimes where the telephone comes in handy. So I think what I thought would be an issue with confidentiality actually turned out to be the opposite. So I saw that as, talk about access to and reducing stigma in terms of receiving services was huge, a huge thing that I saw too. It also, I think another benefit, perhaps an unintentional benefit, has been you get to interact more with family members, because I've also had the opposite happen where people will introduce you, oh, this is my spouse, this is my child, this is my grandmother who I'm caregiving for. You get to know more of that family background and see that in certainly in the video sessions, but I'm also going to say in the telephone sessions where I've literally talked to people about, maybe it's time to have a couple session. Well, my partner's in the next room, let me go get them. And so spur of the moment, things like that happen where it may have taken months to try to arrange something like that. It's absolutely helped. I'll speak about this too in terms of access. I have done sessions at all hours because I'm home. I don't have an hour commute to my office. My patients don't have an hour commute to where I physically was. So that has been huge as well. And especially now what I'm starting to hear with the price of gas and everything else, people are saying, I would be canceling my appointment because I don't have enough money to put in my gas tank to drive to your office. So this works. It works for work schedules. It works for daycare schedules. It works in a lot of different instances. I have a good portion of people that I do see that have chronic pain issues. I've had folks who have had, like I said, surgery. I've had, unfortunately, many people that have been COVID positive who literally would not have been able to come into a facility to have a session. I had one lady who was COVID positive, and I talked to her as she was propped up in her bed. And she very much said to me, if I had to come into an office, first off, I couldn't, I'm in quarantine. And second off, I don't think my pounding migraine headache is going to allow me to do that, but I could prop myself up in bed and I could talk to you this way. So there's some of the things that I have seen, and I'm sure others have had similar experiences too.
Mm-hmm. Thank you, Marietta. Sandra, you have your hand raised.
Thank you. I want to ditto everything Marietta said. It's my experience exactly, particularly handicapped clients during this time. It takes so much effort if you're in a wheelchair to get into an office. And it has been so great to see them in their home or talk to them on the phone. I have a lot of clients in my rural county who don't have internet, but even if they get internet, they can't afford a computer or an iPad. They just don't have those capabilities. But I raised my hand because I wanted to give you a real current example. Have a patient who would drive to the office. It was an hour and a half. She came to see a psychiatrist, and I usually scheduled her for therapy right after that appointment, so she only had one trip to make. Now, she was kind of on maintenance, so she was coming maybe once every 2 months. So I didn't see her frequently, but we had the lockdown and her insurance would pay, but she had no audio visual capabilities. So I was talking to her on the phone. Then UPMC said no more. So she just dropped out of therapy, kept coming to see the doctor, but in 3 months' time, her mood just bottomed out. So she came to see the doctor. She was in such bad shape. He suggested she get back in therapy with me. Well, her insurance wouldn't pay, of course, but she's willing to pay out of pocket so she can have the service. And out of pocket for the agency that I contract with is $100 an hour. So when I spoke to her the first time and we did the whole no surprise billing, a good faith estimate, had her sign something so she understood that. So I saw her the first time a few weeks ago. And because I was cognizant she was now paying out of pocket, I said, okay, I'm going to give you this homework. And when do you think you'd like to talk to me again? Next week. And this will be the third week in a row that she has requested to see me. So just wanted to share that. That's a current story. And I think you mentioned something about UPMC who discontinued that phone only. Okay, thanks.
Yep. Thank you for sharing that.
For sure. I am seeing some good ones, like good reports in the chat, both about just reasons that folks are seeing good access for care. And yes, transportation areas in rural or transportation issues in rural areas is certainly one that a talking point on our list, that folks, you know, who may have needed, like, especially with the low number of available therapists in rural areas, that it may end up being an hour to an hour and a half, 2-hour drive just to go see a therapist. And that if there is a provider in those rural areas, some of those things that that Marietta brought up earlier about folks being embarrassed or feeling that stigma of like being at a therapist's office, especially if it's like in a community where your car might get recognized or you might get seen going in and out of the parking lot, and so somebody might comment on that. And that with that existing stigma that you know, that can be an issue. Marcy, you have your hand raised.
Yes, thank you. And thanks for having this forum. It's been really helpful to hear all this information. So my question is, you know, I'm doing private practice. I kind of started my practice during COVID, right as everything was shutting down. I was, you know, starting this business. And so I've been strictly telehealth this entire time. And every time like I get these emails about telehealth, I'm like, oh my God, is what I'm doing legal, you know, because, you know, I'm concerned. I want to do everything above board and the right way. And so what I heard you say, Johanna, was that before there was no explicit language that said, yes, it's legal, or no, it's not. It's been kind of ambiguous. And so this is why we want this bill in place. Okay. And so for individuals that are private pay, I'm wondering if there is language that kind of addresses that. I know a lot of people take, you know, Medicaid, Medicare, other insurances, whereas I don't do any of that. So if it is strictly private pay, where does the law come in there? Because I'm contracting just, you know, with an individual, and I feel like I had a follow-up on that, but we'll just start with that, I guess. Thanks.
No, yeah, I can definitely answer that because it is that ambiguous, and that it hasn't been, you know, that there is nothing in the law forbidding telehealth at all. The main area of concern is with those insurance companies and those payers. Private pay, self-pay clients, there would be nothing, like, regardless of what happens with the law, or this, unless some other random new law were to pass that like suddenly made it, you know, illegal to do telehealth. Our understanding is that it would not, that regardless of what happens, it's not going to impact self-pay clients. The biggest thing that's going to happen with this telehealth bill is that it will like mandate that insurance companies reimburse for telehealth services, which is kind of what's happening under the waivers now.
Yeah.
Go ahead, Angie.
And it'll give your state licensing boards the authority to kind of put some rules and framework around practice.
Mm-hmm. Oh, that's an excellent point, because I go to all of the licensing board meetings representing NASW-PA, and I can tell you that discussions on that have happened whenever our licensing board was working on their regulatory package. They would bring things up related to telehealth and would end up saying, well, we can't really do that because you know, because of the lack of like a law that would spell out like what their authority was over telehealth. Is there anyone else willing to share like a story about like, in particular, a client who, you know, got care that they wouldn't have been able, like a specific client that got care that they wouldn't have been able to get because they were able to do it through telehealth, or something about like how your clients, again, without breaking confidentiality or anything, would be negatively impacted if the waivers were to end tomorrow, or let's say at the end of the month, if the waivers were to end without having a telehealth bill in place, how would that impact your clients? Cheryl, I see your hand up. Thank you.
Hello. Hi. I have a client who started with me before the pandemic. She has very bad chronic back problems, and she lives a distance away. And she was really not able to come anywhere near as often as she needed to come. She was it was a morning issue for someone in her family who had committed suicide, and she really needed regular treatment. Well, as soon as telehealth came in, that completely changed for her, because now she could see me, she could talk to me every week if she needed to. And it really helped her a lot to get through her situation.
Fantastic. That's a great story. All right, thank you. Hold on, just figuring out the technicalities of like lowering folks' hands and being on mute or not on mute.
I have another
Troy,
one.
and you're, oh, sure, go ahead. Go ahead, Barbara, thank you.
Yeah, this is good because it's helping me reflect back a ways now. But I was working with a young mother who had five young children, 5 children under 12, and the oldest is severely disabled. So we're doing telehealth, and she literally is running like a 1-room schoolhouse with, ages like this. And need I say, she's sort of pulling her hair out. And so our sessions were very much about her being able to take care of herself in the midst of this, so she could be the mother that she wanted to be, but in this incredibly stressful situation. And I think it was really the best work for her, because she became a better parent by being able to really have more self-compassion and find ways to take care of herself within the active parenting. And so there were numerous times that something would happen with one of the children that I got to kind of be with her in the moment, and we could first kind of settle her down before she would intervene with the children. She didn't have to always fly in there to try to correct, but rather than to calm herself down and go in to help support the child to do. And so it was really, it was a great advantage, which would never have happened without telehealth. Yeah. So that's one.
Oh, great. Thank you, Barbara. And
Johanna,
Beverly.
go
Go ahead, Troy.
Well, I was just somebody. We can jump to Bev. I'm cool with that. But Denise was saying, will our malpractice insurance cover telehealth? And the NASW assurance policy does cover telehealth. So if you are insured via NASW and the assurance policy, you just have to make sure that you're also maintaining HIPAA compliance. You're using a HIPAA compliant platform, because you can have some liability if you're not. Most of us will. We know that. You want to maintain tech standards. You want to make sure that you're maintaining, the right antivirus and the right updates on your computer to make sure that your computer itself is safe. And you also want to make sure that you're just kind of staying to the code of ethics. And the NASW code of ethics also has ethics around technology use, which is good to familiarize yourself with if you're not. But the short answer is yes, if you're covered. If you're not covered by NASW insurance, I was with another insurance back in the day where they had riders you can add. Telehealth is a rider. And keep in mind, even though we are all NPA, if any of us is licensed in another state, you also need to defer to that state's requirements and licensures as well.
Right. Which connects to, I think, one of the other comments that Christina brought up about using telehealth to stay in touch with college students during the school year, which is a fantastic advantage of telehealth, but is yet another one that I get a lot of questions about at the chapter office, particularly when when a college student's home and school locations are in different states. It brings up that portability issue, and just a quick answer to that question for, that I wasn't even asked, but that I get asked like 5 times a week or approximately at the office. It matters what the requirement is, where the person is physically located. So even a client going on vacation can be tricky, because if they're physically in, like I had a question about somebody who was going on a missionary trip out of the country, and I'm like, well, it really depends on the licensing laws for that country, or it depends on the licensing laws in the state where they're physically located. So yeah, if your telehealth is crossing state or international lines, you need to be familiar with what the laws are in the state where they're located, and as I said, weirdly enough, that can even apply when your regular Pennsylvania-based client is going on vacation to Florida. It's still it still makes a difference there too. All right. Beverly, you've had your hand raised, so I want to make sure you have the opportunity to share.
I was just going to say that I really appreciated what Troy had to say about his survey. I have worked with several grandparents who are raising their grandkids because of their adult children's opioid addictions. They cannot come into the office, but it works perfectly to schedule when the youngest ones are down napping or whatever. I've also found that in working with some parents around issues with young children, that being able to do virtual has allowed dad to join in on his lunch break at the office and to be a part of the sessions with mom from home by having a 3-way Zoom going. So I have found, it just to provide wonderful opportunities, and many of those folks have said, I would not be here, I would not be participating if virtual was not a possibility.
So I want to, like Aetna, I do a lot of work with some of the national insurance companies, and Aetna reported I think it was close to a 3,000% increase in utilization of services based off of telehealth being an option. Astronomical. And any insurance company is going to have just figures out of the roof for just access and care. And actually a lot of satisfaction surveys that come back, people are highly satisfied with telehealth, more satisfied in some aspects.
Mm-hmm. And I was personally astounded because the people that I had some people that I was working with, and I transitioned to telehealth, and then I had new clients, and I found that there was no disadvantage to even with those folks who started in telehealth. They were consistent, they were very reliable,
Yeah. Well, if someone was missing their appointment, it was a quick reminder, and then they could jump on really quick, right? Because you could deal with that too. And it's like, oh my gosh, I can just jump on, So not a fan necessarily of seeing FaceTime stay as a main avenue. That was an emergency thing, but there's so many Teams and other platforms have been they've worked very well. And I miss personal contact with people, so I'm a big fan of the hybrid world. Some in person and some by telehealth. But for those who love purely telehealth, I think we need to fight and have it be here for because a lot of people do take advantage of that.
Mm-hmm. Just to uplift some of the comments from the chat. Like we've had comments just in general that people struggling with anxiety, sometimes, or like social anxiety, just struggle to be out in general, and that sometimes their symptoms are so intense that the clients vomit, and that telehealth makes them able to access therapy. I love Jill's comment that she'll never know how tall her clients are because it's like weird that you haven't met them in person. And then Amanda shared, and Amanda, if you'd prefer, I can unmute you, but she took the time to write her comment in the chat, which was that she's been able to follow clients to college and maintain care. Would love portability for this, because she now had to get licensed in 3 different states in order to do that. Also had clients that were stuck pre-pandemic in the office with exposure work, but made significant progress with the shift to telehealth, because we were now able to translate their work to the home when they hadn't been able to do that before. And clients that have not done well virtually have been open to coming back in. So they're able to just sort of like shift between the two as needed, now that it's more open. And then Michelle just said that as a school-based therapist, have students that I've met that were in their district's virtual schools, so without telehealth, never would have been able to meet with them. So what I'm hearing is a lot of like access questions, like just improving access to treatment to making it more available to the clients where they are and when they need it, as opposed to having to follow the traditional like doctor's schedule. Oh yeah, and Susan's comment that she just typed in about that the clients didn't need to wear a mask during their telehealth visits, but did in their in-person visits, which sometimes made, I'm sure, made it easier to like read facial expressions and do that had of therapeutic work. So I think that's some really good information. I certainly had been talking about like disability access and certain conditions that might make it easier to like what they were saying about anxiety that might make it more difficult, or the mental health stigma. But these stories about how people are just able to access the treatment when and how they need it, and in those direct situations, like I think it was Barbara's example about somebody who was able to like call in between when they were triggered and when they had to react to it. Yeah, that definitely gives us some real good information to go off of. We're only down to like the last 10 minutes. I can tell you, like, moving forward, of course, if you haven't already registered for Advocacy Day, I think there's frequently a misinterpretation that Advocacy Day is a student event. It certainly is, something that that students attend and benefit from as a means of giving them direct advocacy experience. but it is certainly not limited to, to students. And the fact that it, continues to happen virtually does mean, that we're not necessarily asking you to take a day off or have to travel to Harrisburg. It's really something that you can experience, from your home or office, the same way that we're talking about how, telehealth is beneficial. That you can attend those meetings with your elected official. We have a whole training series of workshops going all the way from March 15th up until the day before lead on the 21st, 11 to 12 every day. We have a panel on mental health NPA with the two chairs of the Mental Health Caucus in Pennsylvania. We have a deep dive on the specific bill, although some of that may be repetitive to what we're just talking about now. But we'll be joined from Natalie Crack from the Governor's Policy Office, who specializes in some of this telehealth information. We've got panels on communicating with your elected official. So all of that is possible. You can, if you register for it, you can attend as little or as much as you want. It's $10. It's only $10 to attend if you don't want CEs. If you do want CEs, you can get up to 6 for $50. And you can access the recordings. You'll be able to access the recordings even if you're not able to make it at that exact 11 to 12 time. So I'll put the link to lead in the chat. If CE-wise for this, just to note that you'll be getting an email very soon, if you haven't already, that contains a link to the evaluation, and then from there you'll be able to get access to your certificate. But with that and sort of next steps on all of this, again, watch your email for a survey. But I want to check in with Angie and Natalie and Troy to see if you have any closing thoughts before we sign off. Just about I don't know, where we need to go from where we're going from here.
We need to send this recording to every legislative representative in the Commonwealth of Pennsylvania, and they need to listen to it and act upon it.
Mm-hmm.
I took a whole page of notes on the anecdotes that everyone shared. I can't thank you enough for being willing to talk about your experiences through learning this new technology and this new format for your practice. And yes, we were able to kind of give general anecdotes to legislators when we meet with them previously, but these specific examples are really eye-opening and really touching and heartwarming to listen to, and very compelling. So thank you.
You should attend LEAD so that you can tell them those stories yourselves.
Yes.
My shameless plug for come be an advocate for a day.
Mm-hmm. For sure. All right. Well, yeah. I love all of those last comments. I'm sure I'll pass on just word from Christy. Never did, as I predicted, her client in crisis continues to be in crisis. Again, something we've all experienced from time to time. But I know she feels really passionate about this issue too, and would be passing on her wishes for yes, all of those things, to attend LEAD, to share those stories with your legislators. And if you can't come in person, you can always email your legislators during, whether it be on LEAD or another day. Call your representatives. Now is the time, and the message that we need to communicate to them. Again, we've seen them vote for this bill, but what they need to do is to get a clean bill swiftly to the governor's office so that he can sign it and have it become law before the waivers expire. So that's the message and the ask that we're trying to communicate. With that, again, happy Social Work Month. Thank you so much for attending this quarterly town hall meeting. Always love these events. It's so good to hear from many of you and to have these productive discussions. You know, it always gives us a little bit more direction, you know, because we're always kind of taking our initiative and, you know, and going off of what we hear, but having the communication with our members to share back with us what you're experiencing in the field on these important issues really, really is helpful as well. So thank you for being a part of it, and for sharing your feedback and your input. All right, with that, we'll sign off. I'm going to go ahead and stop the recording. And again, watch for that email. If you don't receive it within a couple of days, then feel free to email me and ask me for it. It's not a hardship at all.